So what we're going to talk about today is specifically designed for OB/GYNs. These are specialty 16 providers. That's how you have enrolled with Medicare. And we're going to talk about evaluation and management and preventive services. My name is Ellen Barra, and I'm a specialist with our Provider Outreach and Education Department. And on the line with me today is Aline Ziegler, my friend and colleague, who's going to be watching the chat. She'll be placing some information into the chat for you, and then she'll be also looking for those questions and answers. We do have a lot of information that we're going to provide for you during this next hour. I'm hoping that we do have time for questions that we can take during the presentation. If, however, we cannot, we will be putting together a document with all of the questions and answers, and then we'll be providing that back to all of the attendees. We did have a couple of pre-submitted questions concerning evaluation and management services when you're providing delivery services. We're not really going to talk about that in any great detail during this presentation. We will cover this during a webinar that we're holding on July 23rd, and you can go into our live events webpage, which Aline has placed in the chat for you in order to register for that if you choose to. The next thing that we have is a disclaimer, and we've put together this education to be used by you as a tool so that you bill Medicare appropriately. Our job as the Medicare administrative contractor is to pay you for the services that you have provided to your Medicare patients under the Medicare rules and regulations. As you're aware, if you've dealt with Medicare for any length of time, however, Medicare rules do change. The CMS rules and regulations are the final determinant of coverage along with your documentation. And then the last information on this slide, CMS does prohibit recording of the presentation for profit-making purposes. So we ask that you don't record, you don't do screenshots. We are recording this, and we'll have this available both on our website under the Encore page, and that page actually has a player built into the website. And then we'll also have it available on our YouTube channel. The next information that we have is the AMA copyright notice. We do have some procedure codes and things listed in here for you. We don't own those. The American Medical Association does, and so we're providing you their copyright notice. Some of the things that we're going to talk about today are evaluation and management services and preventive services. We're going to talk about the E&M services and how you kind of choose your level of code. We do have an extensive evaluation and management, choosing your level of service, currently available on our YouTube channel, and we are planning additional education on that. What we have done with this slide is really just gathered up all of the acronyms that we're going to be talking about during today's presentation, so you have them all in one spot. CMS and Medicare, as you know, is really kind of an alphabet soup, so we wanted to provide you with a reference for that. So let's first talk about choosing your level of service. The information that we're going to talk about today is applicable to the professional provision of evaluation and management services. This is not designed as facility billing for a patient presenting for care at a facility, or for the facility billing on a UB04 for any professional services. This would be billing on a CMS 1500 form. It can also include, however, the information we're going to provide is also applicable to rural health clinics, federally qualified health centers, and critical access hospitals billing under Method 2. So the first determinant of coverage is going to be the medical necessity. What's the reason for the patient coming into your office or having that encounter with you today? What you see on your screen is language from the Social Security Act itself. Services must be reasonable and necessary to treat an illness or injury or to improve the functioning of a malformed body member. So that's the first thing, if we look at your documentation, that's the first thing that we're going to be looking for. What are you doing for the patient? Why does the patient need your services provided during that encounter? When Max medical review areas, the comprehensive error rate testing contractor, or other evaluation or evaluation contractors, this is the first thing that they're going to be looking for. What is the actual medical necessity for the service? So the next thing that we have then is talking about the CPT definition of a problem. So this is talking about why the patient is actually there. What is the disease, condition, illness, injury, etc., that is making that encounter necessary for the patient? What it is that your physician or practitioner is actually addressing for that patient. So there's a lot of different things that are considered part of the information itself. In the CPT book, there's information talking about how to define a problem, how to define if you have analyzed a problem. There's some additional definitions listed within the CPT book. One of the questions that we get quite often is concerning what does Medicare consider to be a chronic condition? Well, both the AMA and the Centers for Disease Control indicate that chronic is something where the illness or injury is expected to last at least 12 months or until the death of the patient. So if you're identifying that you have a chronic situation, you want to make sure that your documentation supports that 12 months. We've heard from a lot of different providers that are identifying chronic as either 3 or 6 months. And based on the AMA definition, it is 12 months. Another thing or term that is part of the evaluation and management is concerning a stable condition. The AMA again provides that definition, but it really means that the patient is at goal. So for an example, you want the patient's blood pressure to be at 120/70, for an example. If the patient is at that, then they're at goal and then they're stable. If they're not at that, then they're not at goal and they're not at stable. So the definition stable would not apply there. You would really have an exacerbation of that chronic condition. Even if their blood pressure has been at 150/100, for an example, for the last year and a half, they're still not where your physician or practitioner wants them to be, and therefore it is not a stable condition. Another thing that's listed within the CPT definitions, talking about problems, is an undiagnosed new problem with an uncertain prognosis. Well, what does that mean? Well, that means number one, that it's something that the patient, it's not diagnosed for them yet. Now, one of the questions that we get in this particular area is especially dealing with specialists. The patient has been diagnosed at their primary care office, for an example, with whatever the disease or illness is, and now that patient is coming to your office for further treatment of that problem. Well, it's not an undiagnosed new problem at that point because the patient does know what the diagnosis is. So, an undiagnosed new problem with uncertain prognosis, both of those pieces of that definition are important. It's a new problem to the patient, it's undiagnosed, and there's uncertain prognosis. We don't know for sure what's going to happen yet. We have other questions that we have received concerning what are systemic conditions. That's part of the CPT information under problem. Well, these are body systems such as cardiovascular, musculoskeletal, respiratory, etc. And so it's something that is affecting the whole body in addition to the particular problem that you're addressing. Another question that we get quite often concerning problems has to do with what does the word severe mean? Well, severe is really going to be determined by your practitioner, and they need to document that within the medical record. So, for an example, if you have a patient coming in with a pregnancy, and everything is going along just as it's supposed to, then your patient would not meet that definition of severe. If the patient, though, is having some type of difficulties with that pregnancy, then how they define that and how severe they think those problems may be really is based on that practitioner's determination for that individual patient. And then they would need to document their thought process to that. And documentation really is the thought process of your physician or practitioner. Another question that we get quite often concerning the problem part of medical decision making is, can you count a high level when the patient has multiple chronic illnesses? Well, you want to again look back to those definitions within the CPT book. You want to look into those charts that CPT provides and look at the different definitions that fall within each of those levels of problem. In some situations, for an example, if you look at the moderate problem level, this is one or more chronic conditions. So you want to look at your data also look at your documentation rather for the data and the risk that your patient is experiencing. You must meet or exceed two or more of the elements, which of course are the problem, the data, and then the risk to the patient. Another question that we get quite often is, well, what are examples of self-limited or minor problems? Well, the AMA defines a problem, and it says a problem that runs a definitive and prescribed course. It's transient in nature and is not likely to alter the health status. So this could be a cold, it could be a sprained wrist, something along those lines. Another question that we get is talking about acute complicated injuries. Again, you want to look at the definition. It all goes back to that provider's documentation and to the provider's proof of thought as to what is happening with that particular patient. The next thing that we want to show you here is the CPT definition of a problem that has been addressed. Now, for your particular specialty, OBGYN, you're going to have patients who are over age 65 and eligible for Medicare, but you're also going to have additional patients that are eligible for Medicare based on disability, for an example, that are going to be younger than 65. Well, when we're talking about patients over 65, they can have a multitude of different diagnoses or issues that are happening for them. What you want to look at, though, in your documentation is what is the physician or practitioner actually addressing during that particular encounter. So, for an example, the patient may have breathing difficulties, or they could have cardiovascular issues or something along those lines. but the patient is there today because they do think they might be pregnant or because they are there for birth control or something along those lines. So even though the patient may have these additional issues and concerns, is your physician or practitioner addressing that during that encounter? So for an example, if you have a patient on which you're choosing to do surgery, do you need to address that patient's diabetes as an example in order to determine what you believe is going to happen with the healing process and the anesthesia and everything else that goes along with that, with whatever service you're providing them? Does that play a part in, and is that part of the proof of thought for what the physician or practitioner is going to be doing for that particular patient on that day? The next thing that we want to talk about then are the data categories. And this is information that you're looking at. It could be test results, could be ordering tests, it could be looking for other pieces of documentation from other physicians or practitioners, other hospital stays, something along those lines. And so you can see here we've got two of the different levels on this slide for you. Well, the straightforward level is going to be minimal or no data that you're looking at. For the low category, you have to meet at least one of the two categories under that low level. And these are going to be tests and documents, and you have to have at least two. Or it can be an assessment requiring an independent historian. For the category 2 there, the independent historian, documentation will need to show who's the independent historian, why did you need an independent historian? So this is not a mom coming in and talking for her daughter. It's not a mom coming in and talking, or a daughter coming in and talking for her mom, something along those lines. But it's situations where the physician believes that the information provided by that patient is not to be totally trusted, and you need additional information. So in your documentation, then you'll again document who did I talk to, and what type of information did I get from them, and why did I need to get that? The next slide that we have has the moderate and high level. So for moderate, we have to meet one out of three categories. So this is going to be testing, and it requires at least three. Independent interpretation of tests can also go in this moderate level, as long as you're not billing separately for the independent interpretation. And then that last one under moderate is discussion of management or test interpretation with other practitioners. So you need to have a conversation, for an example, with the patient's primary care practitioner concerning an aspect of their care. You'll document that, why you needed to have that discussion, and then what was that discussion, and how are you using that information then in the care of your patient. You'll notice the independent interpretation has now moved into category 2 as opposed to being in category 3. One of the areas of confusion seems to be in looking at the review of a test and ordering a test. Well, when you order a test, the review of that is part of that order. You're not going to be ordering that test unless you need that result for something. So you would not count those separately. You order a complete blood count, for an example, for the patient, you would count that once as both the order and the review of that test. However, let's say that you ordered a lab test for the patient, you see them in January, and you're ordering some type of monthly test for that patient or a quarterly test for that patient. Well, in today's encounter, even though you ordered four of them, for an example, you're only going to count it once. When you see that patient again and you're now evaluating those test results, you can count that test again, however many times you have that patient has taken it before that next encounter, you can count that once because those are single procedure codes. They're considered a unique test. If you order additional testing, then you would have an order and then the review of that previous testing. So let's look at data analyzed. This all goes back again to proof of thought. And what you have up on your screen is the AMA definition of that. The practitioner is reviewing or analyzing the test results to help determine their plan of care for that patient. When you see the patient in June and you analyze those previous test results, this will help you determine that new plan. This could be keeping everything the same. It could be making adjustments, whatever is needed for that patient. The testing is presumed to be analyzed. Again, it goes back to the medical necessity. If you're not going to use the test results, then, kind of why are you ordering the test? We did have a question from a provider one time that said, well, I only need to order one test for the patient. Do I need to order additional tests so I can increase my level of data? And the answer to that obviously is no. You're going to be ordering what you need, what your physicians and practitioners need in order to treat that patient appropriately. Then we have what is the AMA definition of a test. It is imaging, laboratory, psychometric, or physiological data. A unique test is based on the procedure code with one exception. If you have a procedure code that includes other services, such as a lab panel, then that would all be considered under one test. You wouldn't count the individual test under that panel code. You can also see there that pulse oximetry is not considered to be a test. For category 2, for both the moderate and high areas, you can also provide that independent interpretation. Now, when you're doing an independent interpretation, this is really bigger than a review of the test results or a review of the x-ray. You're doing a report. So it's going to be similar to what a radiologist would provide in doing that professional component of that particular service. So that means your documentation then is going to include that report. Now, whether you do that as a separate document or as part of your medical record for that encounter, that's really kind of your choice. Medicare would have to be able to see in that documentation, though, that it is a report, not just a review of that data. And then again, we've talked about the testing. We've talked about a unique test identified by the CPT code, but there's another aspect of unique also that we need to discuss. So for an example, if you take a look at the records from the last three emergency room visits from ABC Hospital, this is considered one unique source. It all came from ABC Hospital. If you're analyzing the testing results from those same ER visits, you can also count that as a unique source, and the AMA has published that information. This is not, however, a review of your previous medical records. It's not a review of other medical records from physicians in the same group with the same specialty. It can, however, include review of records from someone in your group with a different specialty. And remember, Medicare views specialty as the two-digit specialty that the provider designated with when they enrolled with Medicare. So an example could be a cardiologist is reviewing the medical record of an internal medicine provider from the same group. That would count as a unique source. Well, what about situations where you had an encounter 3 days ago, for an example, and the patient calls back and gives you additional information and you order a new test? Well, this would not be for the encounter 3 days ago, but you can count the review of that test in that next encounter you have with the patient. The next thing that we have is discussion defined. And this is a real-time discussion between practitioners. Now, this could be emailing back and forth, it could be talking or texting back and forth. The AMA has stated, however, that it is not notes within the patient's medical record. So if you have both the cardiologist and your specialty and you have a shared medical record, leaving notes within that medical record does not count as a discussion. This is going to be a discussion of patient's care. This could be a conversation with the practitioner who read the x-ray to discuss the results. It doesn't necessarily need to be on the date of the encounter, but we would expect that exchange to begin on or right after the encounter. And then we would really expect that that would be completed within a day or two. Now, until that is completed, that exchange of information is completed, you would not be able to count that when you're choosing your level of service. CMS also has the risk defined for you. It's the probability and or consequences of an event. It is the assessment of the level of risk based on the medical decision making for that problem during that encounter. So this really goes back to what the physician or practitioner is identifying as the risk to that patient. So let's say, for an example, you have a patient with a stable chronic condition and you knew that you renew that patient's prescriptions. Well, what's the risk to that patient from the encounter? Is it a new medication that maybe, there's side effects that you need to watch for? Is it a medication the patient has been on for a while and you're evaluating and treating the side effects? Um, so you need to look, the physician and practitioner really is the one who needs to be determining that risk level for that particular patient. It all goes back to proof of thought. What is the probability or consequences anticipated for that patient from the plan of care or the medical decision making that has been made for that patient? So prescription drug management is one that we do receive a lot of questions on. Prescription drug management is listed as one of the examples for the moderate level of risk. However, they're examples. It's not an automatic thing. If you renew the patient's birth control medications or renew other types of medications, that does not always make that situation fall into the moderate category of risk. In some situations, the patient could be high level risk based on the medication you're ordering or that they're taking, etc. In other cases, it could be a low level or straightforward level. When we're talking about prescription medications, this can also include supplements, other types of over-the-counter medications. or things the patient may be taking when that's managed by the physician and it provides a risk to the patient. Again, goes back to that proof of thought. My patient is taking this supplement, they're also taking this medication, or they have this illness. How is that all going to work together? And so again, I just want to support your physician needs to be telling you within that documentation what that level of risk is for that particular patient. The next thing that we want to talk about then is choosing your procedure code based on time. Um, the time is spent on that calendar date. This can include both the face-to-face time and non-face-to-face time. When you're documenting time, you would need, your physicians and practitioners do need to document a specific time, not a range. Now, we're not expecting the physicians to kind of stopwatch themselves, but they do need to identify specific times and then what it is that they're doing. CMS has instructions for the contractors that if we're reviewing medical records for E&M services and that procedure code level has been based on time, we do have to review that for the accuracy of the time. So what that means is we're going to be looking at what was done, both face-to-face and non-face-to-face, and making sure that that time makes sense for the amount of time that has been provided. Now, do you have to sign one of the questions is, do you have to sign your documentation on the same date to count that, to use time? And the answer to that is no. You can sign on a later date. Now, obviously, time you spent on that later date is not part of the time for the encounter. The other thing I want to draw your attention to here are the non-face-to-face services. Don't leave money on the table. If you're choosing your level of service based on time, make sure your physicians are documenting this is what they're doing. They're doing these non-face-to-face services and how much time they're spending on those. That can make a difference in the level of service that you choose. So you can just see some examples here, preparing to see the patient, performing the exam, counseling and educating the patient. On our next slide, if your physician is taking time to order those tests, that type of thing, that's part of it. And then look at that third bullet point there, documenting the clinical information in the medical record. If your physician, after they leave the office, they spend another 5 minutes documenting what they have done, count that time. That goes into the total encounter for that particular day. And then the last two you can see there, if you independently interpret a test, if you do care coordination, but you're not separately billing for that, then you can count that time. If you're going to bill separately, then you would not count that. We have a new service for 2024, which is the procedure code listed on the screen for you, the 99459. This started being payable by Medicare as of 1/1 of 2024. It's an add-on code to your evaluation and management service. These are listed within the CPT book. The final rule, and this is where there's some confusion that has come in. One of the questions that we've received asks whether or not you can only use this if you have a chaperone present when performing that pelvic exam. CMS instructions do not state this. The information that was contained within the final rule is that the chaperone or the additional staff you have in that room, that's how they did the pricing for the service, but there's nothing in the final rule, the CPT book. CMS instructions say you can only use this if you have a chaperone. So if you're doing a pelvic exam, I think in most cases you have someone else there. you can bill this. Even if you don't have someone else there, you can also bill this. The next thing we want to talk about is the add-on complexity. And this is a procedure code that I think providers get a little confused on, but really it's not as difficult, I think, as providers are kind of making it out. Okay. So what you have to have within this, in order to build this procedure code, number one is you have to have an encounter, and this is going to be your new patient encounters, your established patient encounters, etc. And then the big thing that goes along with this is the relationship between that provider and that patient. And there's two things that Medicare says you have to have one or the other. Number one, you serve as the focal point for all of the patient's healthcare needs. So, as an OBGYN specialty, in a lot of cases, for a lot of patients, you're really their primary care practitioner. They don't go see anyone else. You are the focal point for their healthcare difficulties. The other situation is that you have, or your patient has, a single serious condition or a complex condition, and you have that long-term relationship with them. In both of these situations, you can build that G2211 procedure code every single time you see that patient, as long as it meets the definition that's provided up here on your screen today. Another question that we often receive about this one is the patient's primary doctor is not here today, but another provider in the same practice with the same specialty is seeing the patient for the same reasons that they would have seen their normal practitioner. Can you use it then? And the answer to that is yes. Providers with the same specialty in the same group, Medicare considers them to be the same person. One pre-submitted question that we had is, can you use this even if you see the patient only once a year? And the answer to that is yes. If you are serving as their focal point for all their healthcare needs, then yes, you can certainly use that, because you're their provider. You have that longitudinal or long-term relationship. Another pre-submitted question that we had is, can we only use this if we're addressing a serious condition or a complex condition? And the answer to that is no, if you're the focal point. Now, if this applies to you based on medical care related to single serious condition or complex, then documentation has to support that definition. And as long as it does, bill the procedure code. Don't leave money on the table. This is a procedure code CMS designed specifically so that providers who have these long-term relationships can receive additional payment. And so use it if it applies to you. So what happens then if you're no longer the focal point, or you're no longer treating a serious single condition or a complex condition? Well, at that point, you don't use the code any longer. If you have let's say, a complex pregnancy going on, once that pregnancy is done, then we no longer have a single serious condition or a complex condition. So you wouldn't continue to use it if you don't meet that first bullet point there. Medicare does not restrict the use of this code to any particular specialty. Documentation is going to show that relationship between the patient and the practitioner. And then here are the eligible providers for that. You can see that a critical access hospital method 2, you can build this separately under that type of bill 85X. For RHCs and FQHCs, you're not going to receive additional payment for that, but you do include that on your claim. You can, the next thing that we have is talking about place of service codes. And these are the place of service codes to which this procedure code applies. Again, on frequency, there are no frequency limitations. If you meet the requirements, the longitudinal relationship for either where you're the focal point of their healthcare needs or the single serious condition or complex condition, you can bill it for every encounter you have with that patient. The patient does have cost sharing and deductible that applies to that. The other thing that for 2024, CMS has published that if you're also billing another service, let me rephrase that. If you're billing your evaluation and management service using a modifier 25, where maybe you're doing a procedure on the same date, you're performing a preventive service, an annual wellness visit, something along those lines, you would not use the G2211 then. You would simply submit your services that you're providing. You do want to make sure, however, that you're providing this using that modifier correctly. We see all kinds of claims coming into Medicare that have appended that 25, but it's not necessary. So what you want to do is you want to take a look at our modifier fact sheet on modifier 25. It's available on our website, and make sure you're using that modifier correctly so that you're not going to receive a denial for that G2211 procedure code. Documentation is going to look to support that longitudinal relationship, whether they're looking to you for a focal point of their healthcare, or again, the single serious condition or complex condition. We've had questions concerning this procedure code in a teaching physician situation. This does not apply, or let me put it this way, the teaching physician cannot bill this under the primary care exception. That's that modifier GE. They can bill this under the teaching physician guidelines when they append that modifier GC, which means that teaching physician does have to be present. And then this is listed as a telehealth service. And that's okay, but I mean, it's really not a specific service like that. However, if the service you're providing is appropriate for telehealth and you meet the qualifications, then you can bill for this also. The next thing that we have is social determinants of health. And the first thing I want to remind you is that this is not a screening. The procedure code, which I'll show you on the next slide, is for the assessment. It's where the physician and practitioner is using that information that was done in the screening or in information that the patient has provided to you, and they're using that as part of their medical decision making. You can see the procedure code here, the G0136. It says 5 to 15 minutes, but if you go over 15, currently there isn't an additional procedure code that you could use. Medicare would not expect that you would use this more often than once every 6 months. And again, you want to make sure that your documentation shows how you're using that information to help you make your medical decision making. There are several examples within the Medicare Learning Network Matters article on this. The patient's calling for an appointment and stresses they can only come at a certain time because of transportation issues. Well, that's a situation that's going to make a difference in your plan of care for that patient. And then we have the reference to that at the end of our presentation. So this is information that you need to be gathering within your screening, that you'll be assessing during the actual assessment that you're providing for the patient. Housing insecurity, food insecurity, utility difficulties. I actually live in Texas. We've been over 100 for the past few days. That can really make a difference in people's health. There are tools that you can use for that, and we provided you just some there. We do have the list of those documents within the CMS MLN itself. You can provide these services with E&Ms other than that 99211 that's there. You can also provide this assessment with behavioral health office visits, and we've listed those for you. And then cost sharing does apply to this. It's always a good idea to let the patient know that cost sharing will apply. And then if you're doing this on the same day as an annual wellness visit, you append modifier 33 to that. And what that will do is it will change our processing where cost sharing does not apply. Now, it does have to be billed on the same day and on the same claim. And if the annual wellness visit for some reason denies, maybe too frequent or something along those lines, then cost sharing will apply to that social determinants of health. You can see here Medicare will allow this in both a facility and a non-facility setting. And then it is available through telehealth when you're doing that companion code through telehealth. We've got documentation listed for you here. Again, it goes back to that proof of thought by your practitioner. What are they doing within their medical decision that is affected by this social determinants of health assessment? Are they having to change a medication because the provider can't afford it? Are they having to change a medication because that has to be refrigerated, but the patient is homeless? You know, what are the changes they're having to make? And then you can use a Z code on your claim form, but it's not required. What you'll use is going to be the reason for your encounter. For an RHC, it is provided with that companion service. Payment for that is included with that companion service, and then no cost sharing applies to that. The next thing that we have then is the clinical breast and pelvic exam. And you can see the procedure code there, the G01001. There are frequency limitations for that. You can do annual for a patient who is at high risk, and this is going to be based on the patient's diagnoses. And the reference material for this has those diagnoses listed. It is going to be, and then one of the things for high risk could also be childbearing age with an abnormal PAP within the past 6 months. If the patient is at low risk, and again, that goes back to the diagnoses, then Medicare will cover this once every 2 years. What we have on the next couple of slides for you are the 11 elements that are part of a clinical breast and pelvic exam. You have to have at least 7 out of the 11. One of the questions that we have received quite often is, well, I don't have all 7, I have 6. Well, if you only have 6, then you didn't provide this particular service. It doesn't support the procedure code. So elements 1 and 2 are listed for you here. Elements 3 through 8 are listed on this slide, and I'm not going to read them off for you. And then 9 through 11 are listed there. You want to make sure your documentation supports at least 7 of those 11 elements. The next thing that we want to talk about then are the screening pap smears. And you can see the procedure code there. There are also multiple procedure codes that have to do with the lab service itself. And let's talk about that for just a second. And this is an error that we see quite often. The physician's office has obtained the pap smear and done the work for that. That's the Q code. They have then sent that off to the laboratory for them to evaluate the specimen. That's the G codes or the P3 codes that are listed there. In order to bill for those codes, you have to be a laboratory or you have to have the CLIA number. So if you're actually performing the pap smear itself, then your office would have to have a CLIA, which is Clinical Laboratory Improvement Amendments, that go along with certification for that. And then you could bill for the actual lab test. Otherwise, what we see a lot of times is the providers billing, physicians billing for both, and then the laboratory comes in and also bills for that pap smear. In a lot of cases, those get denied, unfortunately. And then you can see the frequency there at the bottom of your slide. We also have cervical cancer screening with an HPV test, and you can see the procedure code is listed there for you. Patient eligibility, this is going to be patients, female patients aged 30 to 65. So it's not going to apply to a lot of your Medicare patients who are over 65. You can see there, Medicare can allow this once every 5 years. There are specific diagnosis codes that you need to include, and then this is billed in addition to the pap smear itself. Okay, so the next thing that we have is questions. We do have about 7 minutes left on the webinar itself, so I know we're not going to be able to get to all of your questions, but we'll go ahead and start. Anything we're not able to get to, we will provide back to you. Aline, you want to read off the first question?
Sure. Thanks, Ellen. I'm just going to go in the order in which they were received. And the first one comes from Lynn. What is your stance on pregnancy being an acute or chronic condition? The Society for Maternal Fetal Medicine has the stance that it is chronic. What is our stance on that?
Well, remember I talked about earlier that a chronic condition has to either be expected to last at least 12 months or until the death of the patient. That's the AMA definition of chronic. It's also the Center for Disease Control's definition of chronic. So your pregnancy is not going to fall into that category. What you'll want to look at are the definitions for the problems in your CPT book to determine where this individual patient falls. Again, for Medicare reimbursement, you're dealing with patients with some type of disability. So you want to look at everything that's going on with that patient in addition to the pregnancy, to determine your level of problem. Next
Thank
question.
you. Next question comes from Kelly. If a provider writes a script for a medication that is available over the counter, does WPS consider that prescription management?
It can be if the documentation supports that. Now remember, prescription drug management tends to be kind of an area that we want to talk about a lot, because the act of ordering that medication, whether it's a prescription, whether it's an over-the-counter medication, that doesn't necessarily mean that your risk level is moderate. However, in the question that you have, if they're writing a prescription and that is necessary for that over-the-counter medication, such as a higher level of ibuprofen or something along those lines, then you could count that as prescription drug management. Next question.
Okay, this goes to the pelvic exam. For 99459, does the patient have to be offered a chaperone in order to bill?
No, CMS did not say anything about that in the final rule. The CPT does not address that. in my experience, there has usually been a chaperone there when the provider's doing a pelvic exam. That's kind of the determination of any state regulations and things that you may have, any business practices that you may have. But no, you don't necessarily have to offer in order to build that code. Based on the information that CMS provided and what is in the CPT, it is simply a code you can bill when you do a pelvic exam. And that is the last question that we're going to be able to take. I've got some other things that I need to kind of show you here. Again, whatever is in the chat, whatever we get as follow-up questions, we're going to put those all together in a document and it will be sent out to everyone. We have provided you here with multiple resources. Social Security Act information, AMA information. The third bullet point there is the one that addresses the AMA stance on prescription drug management and reminds providers that it's not automatically a moderate level. Okay, so you can take a look at that. We've got the internet only manual. The 30.6 is your E&M information. Section 100 is going to be your teaching physician guidelines. We've got some CMS publications here. There are two there on the G2211 procedure code. One just provides you some information. One is concerning the modifier 25. We also have the national coverage determination on the screening pap smears and pelvic exams. We have information there for you on preventive services. This particular link will take you, it's kind of an interactive website. The first thing that you'll see is a chart that has all of the preventive services listed on it. And then you can click on the preventive service you're interested in. The next MLN talks about the health equity services, which includes that SDOH. It also includes principal illness navigation, and then community health integration. And then there's one more, and that one has just gone out of my head, but that includes all four of those. We've got information on the Medicare wellness visit, as we talked about. As an OBGYN, a lot of times you are the focal point for that patient's healthcare, and so you may be providing these wellness visits to them. We have information on the National Correct Coding Initiative, procedure to procedure edits, information for RHCs and FQHCs, and then also that modifier 25 fact sheet. Providers notoriously are not using that modifier correctly. They're adding it on things that they don't need to add it onto. So you really want to look, because if you're using that 25, you can't use the G2211 code. And we want you to be able to use that whenever you can. Another thing I want to let you know about, CMS and Noridian are hosting a conference on provider enrollment. This is going to be in San Diego, August 28th and 29th. The link in the presentation and what Aline has placed into the chat for you is where you can go to get the description and the registration for that. The conference is free. Obviously you have to pay for your travel, but the conference itself is free. So on behalf of Aline and myself for today, we do want to thank you for attending. The questions that you provided to us already have been very interesting questions. I'm sure the rest of them will too. We do encourage you to take the survey. That feedback is very important to us. One of the other things you can do on that survey is to provide us with additional education you want. So if there's an additional procedure code or topic for your specialty, let us know that. We can include that in future education. So on behalf of WPS, thank you so much, and you can now disconnect. Have a great day, everyone.